Today I'm going to be talking about management of dental emergencies that present to general dental and medical practice, and also to allied health. So I'll just share my screen. Please, if you have any questions during the presentation, feel free to unmute yourself and fire away, and also you can use the chat function as well. So I'll just load up the PowerPoint and then we'll get started. Thank you very much all for joining us. Now, can you all see my screen okay? Yes. Some of you will have a fairly basic understanding of dental emergencies, and some of you will have more detailed understandings. And my goal today in the talk is to expand through a more solid foundation your ability to manage dental emergencies that present to you. The presentation will discuss dental terminology, atraumatic emergencies such as infections, and traumatic emergencies, and we'll give you some guidelines on management and the underlying cause and treatment. Dental terminology. I've tried to use a standard sequence so that you'll understand there's a few different ways that we can utilise dental terminology. The most common is through the FDI notation, which I've demonstrated here. In permanent teeth, they are numbered in 4 quadrants. The upper right is quadrant 1, upper left is quadrant 2, lower left is quadrant 3, and lower right is quadrant 4 in permanent teeth, with the teeth numbered 8, which is the wisdom teeth, through to 1, which is the central incisor. In the baby or primary or deciduous teeth, we have 5 teeth in each quadrants. The quadrants are marked the 5, the 6, the 7, and the 8 for the upper right, upper left, and lower right, respectively. And they are designated by letters rather than numbers. If we look at tooth anatomy, this is a sagittal slice through a molar crown, and it demonstrates the basic anatomy of a single tooth. It shows the structures that we will be talking about today, including the enamel, which is the hard outer shell, the dentine, which is still heavily mineralised at around 70%, which is the inner part of the tooth. That's what tends to get quite sensitive or cause sensitivity when exposed to the outside environment through trauma or through wear. And then there is the pulp, which is the neurovascular bundle that surrounds or fills in the centre of the tooth, the supporting structure, which is the periodontium, of which the bone and then periodontal ligament form, and then the surrounding alveolus around the tooth. In 2011, there were 11 deaths in Australia due to dental infections. Dental infection, unfortunately, is still a significant issue in certain parts of the community, be they immunosuppressed, be they low socioeconomic, or be they remote and regional, and it can have quite dire consequence and very severe implications for people if they're not appropriately managed. Largely, the atraumatic emergencies are infectious in nature and normally present as pain. Before dismissing the case as a dental or apical abscess, let's learn about the spectrum of this disease a little bit further. Now, there are 2 pathophysiologic processes that account for the majority of atraumatic dental emergencies we see. That is a dental disease or periodontal disease. Now, here you see slides about what we call periapical abscess. Dental diseases refer to infections involving the enamel, dentine, cavity, pulp cavity, and root canal. It starts with dental decay, or more properly referred to as caries. Caries leads to localized inflammation in the nerve or pulp, and that is known as pulpitis. Patients classically refer to this as toothache. Now, pulpitis can either be reversible or irreversible. Either way, the patient will need to see a dentist. Antibiotics do not work in the case of reversible or irreversible pulpitis. Dental caries and dental pain alone is not a dental emergency. However, if the caries persists and goes untreated, the bacteria eventually will cause the nerve to necrose, and this is where we have a situation where in the last slide we then get localized alveolar bone loss at the apex of the tooth, which is known as a periapical abscess. If this abscess is then allowed to spread, it is likely to cause facial swelling, which is a dental emergency. Subsequent erosion of the cortical plate of the jaw allows bacteria to spread along the deep tissue planes into facial spaces of the face and neck, and depending on specific tooth or teeth involved, and the site depends on where this space spread goes as to the site of erosion. And we'll find out why in a little while. And so you can see a picture of some carious deciduous teeth. These are baby teeth, and a buccal abscess adjacent to there. You can see a submandibular and buccal swelling on a patient here. Diseases of the periodontium involve the gingiva, periodontal ligament, and surrounding alveolar bone, i.e. the tissues that surround the tooth. Plaque on the gum margin acts as an irritant to the soft tissues. This leads to an inflammatory response known as gingivitis, or simple gum disease. If the plaque is not frequently and effectively removed, the gingivitis becomes more established. The host defences eventually cause breakdown of the periodontal ligament and the crestal bone, forming a periodontal pocket. This is known as periodontitis. Localized infection of a periodontal pocket can lead to a periodontal abscess. As you can see from this sequence of slides, infections that travel apically towards the tip of the tooth, whether the source is inside or outside of the tooth, will eventually involve the periapical or periradicular area, making this basic differentiation less helpful in cases of advanced periodontal disease, which you can see on the lower right. And my apologies for any of you who are enjoying breakfast at this very time. I'm sorry about that. It's probably a breakfast ruiner. And you can see here, this is the typical pocket abscess. Now, unfortunately, periodontal disease is most commonly asymptomatic, so people do not know that they are actually suffering from the disease unless they have regular dental checkups and unless they have radiographs taken. So in this case, were it not for the purulent area on that upper right central incisor, this patient would not be aware of the disease process that was occurring. For most simple odontogenic infections we have discussed, management is intraoral drainage by a dentist. For our purposes, only attempting to drain localized accessible abscesses in patients that are not seriously ill. The intraoral technique is typically what we will attempt, as infections requiring extraoral drainage may involve multiple soft tissue spaces of the head and neck, requiring more complicated management by oral and maxillofacial surgeons. A periodontal abscess may be managed by incision and drainage through removal of the tooth, debridement of the area, use of adjunct antibiotics such as a penicillin or amoxicillin derivative antibiotic, metronidazole, or clindamycin or erythromycin. Of these, the antibiotic of first choice is either a penicillin or a amoxicillin. If the infection is significant, then use of metronidazole is advised. We also look at use of warm, salty mouth rinses and also chlorhexidine mouth rinses and dental treatment. In the case of a dental abscess, treatment is either incision and drainage, antibiotics, warm, salty mouth rinses, and dental treatment, most commonly either an extraction or endodontic treatment. Fascial spaces. Now, particularly periapical and periodontal abscesses have the potential to break through the cortical layer of the maxillary or mandibular bone and exhibit localized spread to contiguous tissues. They present as pain with swelling or cellulitis and often systemic symptoms. They can progress to involve any of the fascial planes of the head and neck. In immunocompromised hosts, infections particularly will localize and spontaneously drain, but not always. If there is any suspicion of spread to fascial planes, consider impending airway compromise, in particular if they're having difficulty in breathing or swallowing. Management involves IV antibiotics, a CT scan, oral and maxillofacial and ICU admission, and sepsis management. Vestibular spaces, and in this case we're demonstrating buccal abscesses which are draining within the vestibule on both a maxillary on the upper right and mandibular case. Submandibular space and Ludwig's angina. Now, the submandibular space is demonstrated here in red. The sublingual space is demonstrated underneath that. This can lead bilaterally to Ludwig's angina. Ludwig's angina demonstrates complete airway obstruction and the patients look very sick and are likely septic. Examination will demonstrate bilateral, indurated, firm swelling on the floor of the mouth. This is a true emergency as the airway is at risk. The patient will have trismus and generally will have an opening of less than 1 centimetre between the maxillary and mandibular incisors, resulting from direct muscle irritation and involuntary muscle spasm. These cases often involve difficult airway management and require IV antibiotics, a CT, an ENT, OMFS, so maxillofacial surgeon, and ICU involvement, and may require emergency airway management. And you can see here a case of Ludwig's angina as compared to the previous unilateral swelling. This is a bilateral swelling, and you can see that characteristic appearance of the mouth and lower jaw, which is unfortunately demonstrating a really significant infection. Retropharyngeal space is located between the posterior wall of the pharynx and the prevertebral fascia. This space is in direct communication with the base of the skull superior and the mediastinum inferiorly. It has the same characteristic features as an infection of the lateral pharyngeal space and carries a significant complication of descending neck infection. Mediastinitis has a 90% mortality rate. So again, rare that this will present, but if it does, is very, very serious. Again, management is immediate ICU referral, CT, IV antibiotics, and oral and maxillofacial surgeon involvement. The cavernous sinus thrombus is a feared complication of maxillary odontogenic infections. The infection tracks from the canine space up to the ophthalmic veins to the cavernous sinus. In severe cases, this can lead to loss of vision. It presents as a swelling or cellulitis of the infraorbital or periorbital spaces. We have meningeal signs, altered to loss of consciousness to coma. It is likely associated with systemic signs and sepsis and requires early recognition, IV antibiotics, and CT imaging, and again, involvement of maxillofacial surgeons promptly. And we can see here the spaces involved, and you can see the canine space and how it is situated immediately underneath the eye. And that's the canine there, and that's the canine space, and that's unfortunately where it can spread to. Assessment of patients with a presumed dental infection is no different to that required for other conditions. Following a primary survey to assess airway, breathing and circulation, the clinician should take a detailed history, perform a physical examination and order relevant investigations. In the history, a symptom of early dental infections includes localised pain, swelling, halitosis and general malaise. As the infection progresses, the patient may complain of more serious features of trismus, that's limited opening, dysphagia, dyspnea, and the inability to protrude their tongue or swallow saliva, a hoarse voice and stridor, and this indicates a significant infection. In examination, the most important feature on examination is the patency of the airway. If it is compromised, oral and maxillofacial surgeons or ear, nose and throat surgeons should be informed immediately. The face should be examined for swelling and induration. If present, the extent of these features and whether they have crossed the lower border of the mandible should be determined. We should ask the patient to open their mouth as wide as they can and measure the distance between the central incisors. A distance of less than 20 to 30 millimetres, depending on the size of the individual, means it will be difficult to intubate the patient and nasal intubation or a surgical airway may be required. Ask the patient if they can protrude their tongue and swallow, as the inability to do this may be an infection in the sublingual space that is raising the floor of the mouth and posteriorly displacing the tongue. The oral cavity should be examined using a light source, looking for buccal swelling on a visible punctum. Each tooth should be examined individually for appearance, mobility, percussion, and tenderness. The examination should include other causes of the presenting complaint that may be non-dental in origin. For example, tonsillar and salivary gland infections that may cause lower facial swelling and dysphagia, and acute sinusitis or ear infections that can cause upper facial swellings. Investigations include simple blood tests such as a full blood count, electrolytes, an OPG or orthopantogram to assess the dentition. And if the patient has generalised symptoms, blood cultures should also be taken. The severity of the infection can dictate whether the patient requires admission to the ED or whether they can be managed as an outpatient under the care of a dentist. If a patient has significant airway compromise, significant facial swelling or trismus, or is systemically unwell or has other significant medical comorbidities, they will require admission for incision and drainage of the abscess, extraction of unrestorable teeth, and possible placement of external drains. If the patient does not require admission, they should be referred to a dental practitioner for prompt evaluation and consideration of tooth-saving techniques, such as buccal incision and drainage, or endodontics, or extraction and drainage of unrestorable teeth. Many patients and clinicians assume that antibiotics alone are a definitive treatment. This is certainly not the case. Definitive treatment can only be administered by the dental practitioner. Dental infections are often caused by the normal oral flora and are polymicrobial, including a mixture of anaerobes and aerobic bacteria. The antibiotic chosen must target these groups of organisms, and for outpatients, a combination of penicillin and beta-lactamase inhibitor or metronidazole provides appropriate cover. A widely believed myth is that a course of antibiotics is necessary before the extraction of an infected tooth to prevent seeding into the cervicofacial spaces. Waiting for the infection to settle before extracting the tooth can result in life-threatening consequences as the infection spreads along the tissue planes. Teeth can certainly be extracted in the presence of an acute infection. Indeed, extraction of the offending tooth is often curative. It is a pitfall to assume that a course of antibiotics will definitively treat an established infection, and this attitude often leads to prolonged morbidity and the potential for the infection to progress to a life-threatening condition. An appointment to a dentist should be organised for the patient, as this increases compliance. This should be carefully recorded in the patient's notes. Other atraumatic conditions also involve pericoronitis. This is often seen in adolescents with erupting third molars. It will typically require analgesia and referral to a dentist, and potentially drainage if abscessed. More often than not, it either requires the removal of the offending operculum, that's the gum or soft tissue that lies over the wisdom tooth, or removal of the wisdom tooth itself and potentially the opposing wisdom tooth, generally an upper wisdom tooth. But you can see pericoronitis in upper wisdom teeth as well. Dry socket is a lack of clot in an extraction socket upon exam. Generally tends to happen between 2 to 5 days post-extraction, and the patient will present with a notable absence of fever, absence of lymphadenopathy, which would suggest an osteomyelitis or other issues, and an increase in negative intraoral pressure, excessive rinsing or smoking, all increase the likelihood. Of them, the most common is smoking. It is also seen more commonly in adult females in the posterior mandible in particular. Management does not involve antibiotics, and antibiotics will not assist unless there is also an underlying osteomyelitis as well. And so the best management is rinsing and debriding the socket and then placing an obtundant such as Alba-Gel into the site and allowing the area to heal. Traumatic emergencies will often present to general practitioners and to the ED. And again, my apologies if you are eating breakfast, because it's not the most pleasant thing. The most common is fractures, and fractures of the crown, as you can see from this picture. The types of fracture involve an infarction or an enamel fracture. These are easily managed by a dentist and really do not require any further discussion. Enamel dentine fractures, which again are resolved by the dentist and generally tend to cause some cold sensitivity, and what we call complicated fractures, or fractures that involve the enamel, dentine, and pulp. These will require endodontic treatment, either in the form of a pulpotomy, which is a partial root canal, or full root canal treatment. A crown root fracture can also occur, which generally will be manageable by a filling or crown lengthening or orthodontic extrusion procedure. And a crown root pulp fracture can also occur as well, again, often necessitating root canal treatment, and if significant, potentially the need for a crown restoration. A root fracture may be restorable or may be unrestorable, depending on the extent and the location. There can also be localized dentoalveolar fractures of the supporting bone around the dentition, so around the teeth, and jaw fractures, so maxillary and mandibular jaw fractures, condylar fractures, parasymphyseal, symphyseal, and angle and ramus fractures. Jaw fractures are most commonly diagnosed with a CT scan, but they can also be diagnosed on a plain film OPG as well. Luxation injuries involve the displacement of teeth, either laterally, or they can be intrusive or extrusive luxations. In those cases, we call them an extrusion or an intrusion. The types of luxation are concussion and subluxation, which is mild loosening of the teeth. That tends to be associated with a minimal risk of pulpal injury, and patients will normally respond, but still require, even if the teeth are not displaced, dental examination and follow-up. Lateral luxation, where the teeth are moved laterally. Intrusion, where the teeth are forced up into the socket. This is an emergency. In the case of a deciduous or baby tooth, they must be assessed for damage to the succeeding and underlying tooth. And importantly, for adult teeth, there then is the decision as to whether that tooth is surgically repositioned or allowed to re-erupt, which is pretty rare in the adult dentition, or whether it is placed on orthodontic traction and slowly repositioned. There is extrusion, which is luxation out of the socket and complete avulsion, where the tooth is totally knocked out. Avulsions will often present such as this, with the entire tooth knocked out, and you will then have a very swift goal of reimplanting the tooth. Now, this should only happen, and this is very important, for adult teeth. It should not happen for deciduous teeth. Deciduous or baby teeth should never be reimplanted, ever, ever, ever. It's very important, because if so, they can cause infections, they can lead to ankylosis, which is fusion to the bone, and they can significantly damage the permanent developing tooth germ. In the case of an avulsion, ensure that there has been no loss of consciousness, closed head injury, or other significant injury, and attend an emergency department if loss of consciousness or suspicion of closed head injury has occurred. Handle the tooth as little as possible, especially the root area, and try to avoid scraping or rubbing the root surface to avoid damaging the fibres. If you must rinse the tooth, do so with saline or milk, not with normal tap water, as it will kill the cells of the periodontal ligament. Milk is an ideal storage option, and reimplantation within 20 to 30 minutes have great success. Reimplantation beyond 60 minutes has a lowered success, but reimplantation is, generally speaking, the option of choice. It is very, very rare that we recommend to not reimplant an adult tooth, even beyond 60 minutes. So, as we said, number one, hold by the crown. Number two, do not rinse underwater. Rinse with saline if you must. Number three, reimplant the tooth or store it in milk. And number five, please, time is of the essence. There are particular useful forms of storage media. Hank's balanced salt solution is a buffered solution and actually allows you to keep the tooth stored for 24 to 96 hours. This is a fantastic option in the case of significant trauma where the patient has other issues that need to be managed, and then can have the tooth reimplanted subsequently. Tap water and saliva are available when no other options are available. Teeth stored in tap water really, as it's hypertonic and causes cell lysis, can lead to death, unfortunately, of the periodontal ligament around the avulsed tooth. And using saliva in the mouth is a risk of choking. If possible, the patient reimplanting the tooth themselves is advisable if they are going to be further away from a dentist or medical facility, and that reduces and eliminates these risks. Cold milk is very similar to Hank's-based salt balance solution. Often teeth can be stored for 1 to 2 hours. So it is the second order of preference, and it is fairly ubiquitous. So it's a preferred option. So in conclusion, knowledge and simple knowledge about dental anatomy and dental terminology is key. A dental infection can be a impending emergency, and patients need to be aware of the significant consequences of untreated oral infection. Antibiotics alone are not sufficient at all in most cases. Most cases require treatment, which is an adjunct treatment which is undertaken by the dentist. And of course, please all floss. As I always tell patients, you only floss the teeth that you want to keep. Those teeth you don't want to keep, don't floss them. I have got a series of references that's available for all of you at request, and I'm happy to field questions about the presentation. I'll just stop sharing the screen, so just bear with me. Just go out of this. Now, I hope that that was useful for you all. Do any of you have any questions about anything contained in the presentation, or anything that you would like more information about?
My name is Lucy. Is it okay if I ask a question?
Yes, please, Lucy.
So I'm a GP, and I often have patients coming to see me with a sore tooth, And when
Yeah.
I look inside their mouth, I can't see anything wrong, but they're in a lot of pain.
Yes.
And a lot of them don't want to go see a dentist because they can't afford it,
Yes.
and they're wanting antibiotics.
Okay, no problem. Now, Lucy, whereabouts are you practicing? Whereabouts in the state?
In Mount Barker.
In Mount Barker. Okay.
I would say
So,
80% of my patients are on a pension card. And
yeah, no, I understand. There is
so I don't
ease.
know how to approach that situation
Yeah,
quite often.
there is ease of access for these individuals to see the South Australian Dental Service, and there is also a voucher scheme that is available for private practices where patients have a copay which is limited to about $60 for management. In the case of a pulpitis, which is the most common cause of tooth pain, antibiotics will do nothing and pain relief will do very little. So my advice is, unless they have extraoral swelling or obvious systemic symptoms, the best advice is, say, you can go to the dentist, and this is the way that you have to manage this situation. You may not wish to go to the dentist, but that is the only solution, because antibiotics and pain relief won't work. We have an existential issue that's arising within Western kind of medical management, which is unfortunately antibiotic resistance, which I call the looming COVID. It's going to become more and more of a problem because people taking inappropriate antibiotics, as you all well know, does not assist this situation at all. And there's still a community expectation that if I have a dental problem, I get pain relief, I get antibiotics, and then if I want to go to the dentist, I will. These inflammatory conditions, of which pulpitis is one, will not respond at all to antibiotics, and people get a specious association, which is that they take the antibiotics. After several days, the nerve dies. They have a period of acquiescence, and they believe the antibiotics have worked, and then, of course, the infection proper in the periapical tissues commences, at which point then they think, oh, the antibiotics have worn off, I need to get more antibiotics. And then that periapical infection can be managed, or at least controlled for a brief duration after a period of time with antibiotics. And so they come to reinforce in their own mind that antibiotics are the way to manage things. In Mount Barker, I believe, and please don't quote me on this, but that there is a government dental clinic. We also, through the foundation, run a telehealth advice and triage service. So we'll get you the details to all participants of the webinar today. We'll get you the details of that service, and that will help to both triage and manage patients that present with dental complaints, and refer them to the most appropriate venue for management. And that is a statewide program. So that runs both in metropolitan areas and also in remote and regional areas. We have partners with the foundation that work in all of those areas across the state.
Thank you.
Are there any other questions or queries about the presentation or anything else that any of you would like to ask pertaining to dentistry? Excellent. Okay. If not, I'd like to thank all of you for your involvement. This is the first in a series of educational webinars for allied health, GP and medical professionals on dentistry. The foundation has been lucky to be supported by the Primary Health Network in this effort, and it's our goal to improve the oral health of all people living in South Australia. As such, as I alluded to earlier, we have a telephone advice line, and we also have a telehealth offering that is available to both members of the public and medical professionals. We will advise you on the upcoming further webinars and further topic lists. And if there are any particular subjects that you would be most interested in hearing, there will be a survey which will be sent to all participants where you can fill out a variety of questions, both feedback on the presentation, which we would really welcome, as well as ideas about future presentations. And our belief is that there are a few. Those involve the management of patients that are on bisphosphonates, the management of patients that are on blood thinning medications, patients with blood dyscrasias, things like this, and also the management of medically compromised patients and patients with special needs. So they're a small sample of what we're looking at doing. We understand that there is a lot of presentation of dental problems to general medical practice in particular, and we want to try to smooth the way for that for medical practitioners. And also there is a lot of inappropriate presentation to emergency departments of dental problems. And again, we're trying to alleviate the clogging up of the ED and in particular look at strategies that can lead to avoidance of inappropriate presentation and appropriate triage and management. So I look forward to speaking to you all. Again, thank you very much. We will also send out a certificate to those who have participated for your CPD, and I hope you all have a good day. Thank you very much, and best wishes for the remainder of the year. We will probably speak to you in the new year for the next webinar. Thank you and goodbye.